you can have a patient for 6 hours under anesthesia, and, they wake up, and if they don't have pain, they don't need too much pain medication during the night. We don't give morphine or anything like that because the patient don't ask. There are patients that during the night don't take pain medication at all. Because what we are doing is we are not cutting the muscles anymore, we are splitting the muscles to find the nerves, and that what makes a difference. So with that has decreased the amount of pain, and with no pain, the patients are ready to go the following morning. So that's basically the reason.
Thanks for the question. To answer the DBS question, the placement of the electrode is done under local anesthesia with some mild sedation. Patients are, of course, sedated during the opening of the scalp and the opening of the bone to place the electrode, then awake during that procedure. They're not intubated, so they're not under general anesthesia. They're able to speak and answer questions normally, and we do test speech, language, and motor function during the procedure to make sure that there's no stimulation that has side effects. We can adjust the position of the electrode until it's in the right location during that procedure. After the conclusion of that, in terms of the timing, it's about 2 hours per side. So it's a little bit different depending upon each patient, but about 2 hours per side to place the DBS electrode. So for a bilateral procedure, about 4 hours. The patient stays overnight in the hospital, goes home the next day. There is general anesthesia for the placement of the battery, just because not to do so would be too painful. The battery is placed and the lead is tunneled, the extension lead is tunneled under the skin. And so for the actual placement of the battery, which is the second stage of the DBS procedure, it is a brief general anesthetic that's given. That procedure lasts about an hour, and it's done as an outpatient. So on that day, the patient goes home the same day.
All right, here's a question I think would be for Dr. Arce. It says, I have multiple dystonias, cervical, cranial, blepharospasm, takes meds and Botox with selective denervation procedure or deep brain stimulation. I guess there's two of you are going to have to answer this. Deep brain stimulation benefit for this kind of situation. Can you handle that many complex situations in either of those two procedures?
Well, selective denervation is it's only for cervical dystonia. So it won't help the blepharospasm, it won't help the face. It won't help any other part of the body because we are not touching any of the muscles. So it's exclusively for cervical dystonia. So if you have a more complex dystonia, selective denervation is probably not the type of procedure for you.
But you might take a look at how they do in the other areas, because just like our original treatment of blepharospasm with toxin, the cervical dystonia was slightly better. It's sometimes the case that when I and my colleagues are injecting toxin in the neck, the blepharospasm or the oral cranial dystonia may be somewhat improved. So take a look at them afterward, Carlos. You might be helping the other parts too, but I agree, it wouldn't be a primary treatment.
Yeah, well, we have treated patients with for example, blepharospasm and cervical dystonia, and we can help the cervical dystonia. But for example, you have axial dystonia. If your body is involved, then I won't be able to help you, because when you have axial dystonia, you have a very generalized involvement of the musculature in the trunk. And that adds to the neck, to the cervical area. So that's we won't be able to help you. But you have, for example, very isolated blepharospasm and cervical dystonia, yeah, we can help the cervical dystonia. The same applies to face. If you have just oromandibular dystonia, for example, we can do the cervical dystonia, we will be able to help you, but the facial dystonia will continue, So we can help, but it depends on the particular case, But if you have generalized dystonia, definitely we won't be able to help you.
Dr. Bally.
Right, exactly. I agree with that entirely, and that's exactly where DBS would come in, is at the place where it becomes generalized, or if there are multiple or even segmental dystonias, multiple involvement in multiple muscle areas. That obviously the beautiful results Dr. Arce has shown would be fantastic if it's limited to the muscle groups that he can treat, or that can be treated with a combination of that and with botulinum toxin injection. But DBS is very effective for the generalized dystonias or even for the cranial cervical dystonias. Didn't talk about this very much, but Meige syndrome and these other syndromes involving the cranial musculature in addition, such as the jaw, in addition to the neck. That's been treated effectively with DBS.
Thanks.
What happens in patients who've got, an associated scoliosis? Sometimes it's there before the neck dystonia, and the majority of patients have more than just a list. They do have a lumbosacral scoliosis that develops. Do you ever take a look to see if, with the bilateral stimulation, you're able to help the axial muscles?
It's a really interesting question. There's definitely not any great longitudinal studies on that because this field is very new. But certainly people are starting to look at what happens to the spine in patients who have been treated with DBS and after the muscles are loosened up. I would agree with Dr. Arce's comments that once there's a fixed deformity, such as of the neck and also the lumbar thoracic spines, you have to have major spine surgery as well, which is a whole separate situation to fix a fixed deformity. But if it's purely muscle and you haven't progressed to deformity, then I think you can have a major positive benefit.
I have a question for Dr. Patrick. In your opinion, is there any reason to believe this is the disorder is psychological? And if so, would you recommend treatment?
The answer is no. Even when I was a medical student and a resident, and this would have been the late 80s and early 90s, it was in the books, and physicians would tell me that this disorder is primarily a psychological disorder. Patients were all sitting around watching TV. You'd see a lot of patients with twisted necks, one way or the other, or gyrating and twisting and having all kinds of dystonias. And this was due to the medications. They used very strong, heavy-duty medications that block a brain chemical called dopamine. They would all result in various kinds of dystonia, tardive dyskinesia or tardive dystonia, which you've seen mentioned earlier today. And I think there was a perception because of that it was a psychological disorder, but it was actually caused by the meds, not caused by a psychological disorder.
But if a person is depressed, scores for severity on the Toronto Western Spasmodic Torticollis rating scale and for pain correlate with the degree of associated depression. And if our medical treatment of the disorder, the movement disorder, is insufficient, the physician can also help the patient by seeing to it that the mood disorder is also appropriately and as safely as possible treated. And that wouldn't be so much with the old psychoanalytic approach, but rather with sensible forms of psychopharmacologic therapy, which have a high percentage of reducing symptoms, never solving a problem, but reducing the symptoms that may secondarily benefit the movement disorder. But he's absolutely right. People were calling people, the old terminology, remember that in the early 20th century was dystonic neurosis. They thought the whole thing was a psychiatric disorder.
Well, there's some debate about what happens to muscle, and then if there are treatment failures or patients don't respond, there's been a lot of debate and controversy really about what causes that. High on the list used to be immunogenicity. That's actually become lower on the list now. A lot of it has to do with dose, muscle selection, technique, things like that. And then we've looked a lot at this issue of antibodies and immunogenicity, but nobody's really looked closely at what other physiological reasons there might be for treatment failure, changes to the muscle, up-down regulation of receptors, things like that. Now, the second part of the question, if the patient is truly resistant, indeed resistant to type A, speaking for my company, that the type B toxin has proven effective in A-resistant patients. It is a different serotype, and by definition, different serotypes means different antigenicity, different antibody response.
Yeah, maybe I'll not actually from the company side, but from some recent research I saw presented at a meeting about muscle size after many years exposures to botulinum neurotoxins. where they used ultrasound technology, like you see baby in the womb. You can actually look at the size of the muscles, particularly that sternocleidomastoid or strap muscle comes down each side of the neck in patients who have been treated over many years' time. And there's been all sorts of speculation about does it really change a lot. At least in this research model, at least in this one, it was no different than age and gender matched controls who had no cervical dystonia. I'd be interested, though, I think maybe the better answer may come from our expert clinical injectors on the other side, at the other table, either Dr. Duane or Dr. Patek, about if you think that maybe more judicious use of the toxins that have developed over the last few years have, just like it may have changed rates of immunogenicity, have we been able to maintain more normal musculature?
There are two approaches to that answer, and another point I want to add to that at the beginning. I was originally very cautious about initiating toxin therapy. The patients had to have symptoms for 1 to 2 years before I would use toxin. And the reason for that was spontaneous remission rates, where the symptoms essentially disappear, are highest in the early course of the disorder. But Mitchell Brennan, who was then at Columbia and is now with Allergan, convinced me that if this thing shuts down the dystonia, is it not possible, no matter which of the toxins we use, that if we do it in the early stages, we may actually improve the possibility of the remission occurring. I don't know of any hard data that answer the question, but I know for one, I don't know about the first 6 months, but within 6 months of the onset, I'd be willing to use the toxin. So far as change in the pattern, we addressed that by multi-channel EMG that I showed in our presentation in Rome. In 7 out of 10, 70% of patients between treatment 1 and treatment 2, 3 to 6 months apart, in 7 out of 10, the pattern was essentially identical. You didn't have to change the muscles that you injected, the amount, or which ones. But in 3 out of 10, there was enough to change. It was worthwhile to have that information because your dose and your muscles to which you delivered the dose did alter. So there's some variation that sometimes occurs. Whether or not, let's say, there is fatigue of response to one of the commercially available forms of toxin with repeated use, that the switch to another form of toxin, even if it's the same A, for instance, because we've got 3 of that, whether or not that really makes a difference is very hard to assess. But it's one of the things that one might take a look at to see, well, I'm no longer getting a response. If I were in England to Dysport, maybe I ought to try Botox at this point, or vice versa. The same might be true with regards to the Merz product. So it's possible. If there is resistance by frontalis tests, MPA testing, then it should make a difference whether you're using any of the 3. And if you're going to continue with toxin, you would use the B toxin. The difficulty is, now your immune system is primed, and there are regions of the 2 toxins that are similar. So there's a risk that exposure to B, once you're immune or resistant to A, you will develop resistance to B in a variable period of time, in one instance of our patients, to perhaps 6 or 7, that you then eventually become resistant to both. Where A antibodies on their own may clear, in our patients who have developed A and B antibodies, there's 10 years, they're still there.
Okay. Next question. Does having cervical dystonia increase my chances of developing Parkinson's, since the both apparently involve the basal ganglia area? And the second part of the question is, are tremors a normal progression of cervical dystonia? Anybody want to comment on that? Dr. Patek?
The answer to the first part of the question is a quick no. The answer to the tremors part is, as we've heard earlier today, sometimes patients have tremors that may precede the cervical dystonia by several years. Some patients have just a tonic dystonia, head turned in one direction or another and not moving. Other patients have a tremor when they walk in. And some of this may be due to, I didn't get into the terminology of agonist and antagonist muscles. So certain agonist muscles are abnormally contracting because of signals from the brain. They pull the head into the abnormal position, and there are other muscles that try to maybe pull it back to the neutral position. And as long as the agonist muscles are winning, or winning by a wide margin, there won't be another tremor. Sometimes if you come in and inject those agonist muscles and weaken them, then they'll be weakened, but they'll still be a little more active than usual. So now there's more of an even tug of war between the antagonist and agonist muscles, and now you've set up a tremor. One side isn't completely winning, so now there's a back and forth, back and forth. So sometimes you'll uncover a tremor.
And tremor is responsive to botulinum toxin. If you weaken the neck too much, you can augment a tremor. But tremor can be very nicely responsive, and there's where I think dual channel recording of the muscles so you know which ones are involved in the tremor give you a better chance that you're going to resolve the tremor. And Gene, I didn't fully answer your question because you were getting at the point with now reformulation of toxins and greater sensitivity on the part of providers, are we perhaps lowering the rate? And it's my impression that is the case with the patients I treat. But the variables are A, the toxins themselves, and B, I as a treater, I think I'm smarter than I used to be.
Okay, that's after Botox. Don't take Botox before the surgery. Is that recommended?
Good question. You know, each of these cervical dystonia DBS cases are individualized, and the cases I've seen where they're good candidates, the Botox has really started to lose effectiveness anyway. So, so the answer would be yes, but essentially, if it's not working anyway, then the DBS could be scheduled at any time. There's no specific recommendation.
Okay. So, follow-up question on that: after you get DBS, do you typically find that people don't stop taking medications of any kind, or do they continue with them?
It's a good question. There's certainly a population of patients that doesn't benefit completely. I mean, as you saw in the studies that I reviewed, there's only, first of all, there's a gradual effect of DBS, even with good placement of the electrode and with good programming. So it's very significant, but it's also gradual. So out at 12 months in these studies, the patients are getting better by approximately 50% on average symptoms. But there still may be some symptoms that would be responsive to or would need to be treated with medication.
My neurologist gave me a blood test to determine if I was immune to Botox as opposed to the injection test. Is this really effective? What are they looking for?
The only way that would have been done, not the only, but most probable way is that it would have been sent to a laboratory in Northern California called Northview Pacific, and they can only measure for the A toxin using the mouse protective assay. And what we can say is that it's a very reliable test, but it's not completely reliable. The frontalis have done also is another way by which resistance could be ascertained, and probably at lower cost, because it's no insurance company that I know of pays for the test with the mouse protective antibody.
Another question for the botulinum toxin people here. Does resistance to one form of A always cause resistance to other forms of A?
I'd be interested again with the clinical experts, how they would answer this based on their own experience and from research. Let me start by telling you our data from the clinical trials that led to the FDA approval of Dysport and cervical dystonia. And I think this is emblematic of the field, and as summarized by Dr. Duane. We know that when used properly, that is targeted muscles at appropriate doses, that the relative development of antibody is very infrequent with all the toxin A's. In the case of Dysport, that was a required part of our FDA application. Less than 3%, less than 3 out of 100 developed antibodies. Of those 3%, 1/2 still went on to have the same therapeutic benefit at their next dose of Dysport. And so it gets us back to some patients seemingly develop non-responsiveness, but either the frontalis test or the mouse antibody test is negative. So that's weird. Why are they not responding? The flip side is There are patients who develop, high titers of antibodies and seem to continue to have the same response. Sometimes they come together, and then everybody nods their heads and says, "Sure, that makes perfect sense." But unfortunately, it doesn't always. I think we do know from some of the longer-term studies, and there's been studies, for example, with Dysport and with other toxins for over many years outside the U.S. One study went as long as 10 years with Dysport, and something of the patients who remained on, and it was something like 89% of patients remained on, they actually had exactly the same response as measured by an outcome scale that the patient said, am I improved to the same degree? So, and again, I'd be interested what the clinical experts might have to say as well.
Okay. One more comment here.
And then I have another quick comment, as my background is in pharmacology, to just speak about resistance, because what I'm hearing the audience say is, I am on one drug, and I don't seem to be getting the effect that I'm used to. Can I try another drug? Because all these drugs are FDA approved, and you're hearing that they work. So let me just do very quickly, because I know we are pressed for time. When your body has developed antibodies to the toxin, what it is doing is, if you can think of toxin very simply as a circle, and that circle needs to fit into a receptor that's a circle. What these antibodies do is almost make it like a square. So that square can't fit into that circle. And as far as when they talk about antibody titers, what that means is how many of those antibodies have they turned into squares? Is it 10%? Do you have 100%? And really, when you think of it as a pharmacologist, as myself, all of the A core toxins are the same 150 kilodalton toxins. So with the A's, if you do have that actual resistance where you do the frontalis test and you're able to have the asymmetry and you know that there's a resistance, and if they do go forward with the mouse protection assay and confirm there, really there is no data as of yet that says if you switch to another A toxin, it's going to be any more effective. But if anybody has questions, I'm not going to hold you up now, but if you have some just science questions on what is this antibody, I would be happy to answer that for you, and I'll be available.
That's a point. That's a good point right there. I have had some pain on the left side of my head, creating pressure behind the eye, and I've had this personally, so I know it's not. This is not a unique question. Could this be attributed to cervical dystonia? Anybody got to take a stab at that? Do you hear that in your practice?
Yes, possibly. It could be related.
Okay.
Used to be an old,
And it might respond to toxin injection as well.
Okay.
in fact, it was among the reasons why people started using toxin or exploring the use of toxin for headache. The people who had torticollis got results for their torticollis from the toxin, but those with migraine, their migraine wasn't showing up. I've got a patient who's a very good example of that. She loves it for her migraine, and we're helping her torticollis at the same time.
The cosmetic patients.
And I didn't know that. Cosmetics too, okay.
All right, let me see if I can find another one here. Stuttering, a form of dystonia.
Where stuttering fits into the question of neurological disorders is in relationship to tics and Tourette syndrome, and where some people think that stuttering and other vocal tics have something to do with each other. And both stutterers and tickers, vocal phonic tickers, when they sing, don't stutter or tick. So there's some odd qualities about which areas of the nervous system may be activated that will turn off those manifestations, but it wouldn't be one that I would associate with any form of dystonia, not stuttering.
Okay, it sounds like it's a different kind of a mechanism. I'll treat this as the last one because it's going to lead into lunch here. This has to do with diet and nutrition. Has diet and nutrition been studied in relation to CD? And if so, what kind of findings do we have? Is there any way to benefit the condition through nutrition?
None that I know of.
Well, we can run an experiment right now.